Again, if you don't know normal, you cannot discern abnormal. Okay? So it's going to take some time for you to go back and review, pull those concepts up, use the multiple resources you have to do so. Okay? Module B, you're going to have to go back to 105 ABGs. There will be ABGs on the Module B test, and we will not discuss them in class. We can't reteach every course every semester. You'd never get out of nursing school, would you? Okay? But when you've successfully passed a class that attests to the fact, you can bring that information forward. Am I responsible by the Board of Nursing for my health assessment in 1984?
Yes.
Yep, I sure am. I had a successful grade in the course, therefore I'm required to maintain competency in that area. Okay? So we can't forget it and move on. We got to keep building on it and go forward. All right? So let me do something really quickly here because I love the visual part. So there's something we're going to do to kind of help you get the basis for this. I think helps. Okay? Helps me. And I've tried to appeal to all my different kinds of learners. You know, who's my visual, my auditory, my kinesthetic, my reader. Get all those different types of learning styles down pat here. So, we're going to take a little trip. I'm going to add, it'll be quiet in just a second, then I'll pull this up. Oh, 5 more seconds. Okay. This is where we're at. I know where this is at. It's my favorite place in the United States. It's about 4 hours away from where my parents live. It's Jackson Hole, Wyoming. Every time I go home to see my parents, we go here. This is a beautiful, beautiful mountain, little bitty town. And there's a river right behind here. As you turn left here, this goes to Yellowstone. There's this river called the Snake River. Now, I'm just going to hide this for a second because I need you on the Snake River, not traveling right now. I want you to envision the Snake River, okay? It's this beautiful winding river that goes and leads towards the Tetons and then Jackson Hole. Yellowstone. Everybody picnicking with me by the river? Mm-hmm. Okay, there's geese, there's ducks, there's elk out in the distance. It's beautiful, it's serene, it's my happy place. It's cool, it's gorgeous. Okay, so if there was a lot of snow in the mountains that winter, how will that affect the volume in the river?
Rise.
Okay, it's going to rise. How will that affect the force of the flow?
It'll increase.
It's going to increase it, isn't it? We all can see that, right? We see that river. We see it's rising to the banks because the snow has run off. It's melting and it's increasing the volume in the river. Therefore, it's increasing the force of the current. Everybody there with me? All right. What if we were to take the sides of that river and expand the width of it? What will that do? Are we reducing volume?
No.
But proportionately, are we reducing volume?
Yes.
How will that affect the force of the flow in that river, the current? It's going to slow it down substantially, isn't it? Will it, per se, be adequate enough now to go distal? Not necessarily, right? Okay, y'all, there's nothing different about the human body than that. If I have systemic vasodilation, imagine every artery in your body is dilated. Doesn't that proportionately reduce volume? And will it not proportionately reduce the force of flow? Okay, that is our basis for what we're going to be talking about. Bye, Jackson Hole. I'll see you soon, I hope. If I'm sad or lonely or homesick, I'll pull this up on my phone and just watch it. I don't know why. I'll sit there with the audio on, so I can hear the trucks and cars go by. I'm like, yeah. My family and I take pictures of each other at one of those little corners of the moose, the antlers. Nerdy little things. We tell each other, hey, get on the webcam, we're going to be standing here. We really do. We really, really do this. Okay, so let's talk about the processes that lead to the systemic vasodilation. Okay? if you were to, when my son, a long, long time ago, when he was taking down a big tree house he had built, and I got tired of looking at it because he wasn't playing anymore because he was older, I tear that thing down. So he was breaking it down, and as he stepped on a 3-inch rusted nail, partially embedded into his heel, through his shoe. Okay, if I were to look at that heel, nails out, we're looking at the heel, hemostasis takes place pretty quickly in a healthy individual, right? So we've got some clotting going on. That's part of that inflammatory process. What's going to happen to the site locally? What's it going to look like? Okay, why is it red? What causes that?
The normal response.
Okay, but in what part of the normal response is causing the redness? Very specifically. Okay, because of our histamine response, we're going to have localized vasodilation. Localized, which is why we've got an area of redness, but it doesn't spread beyond that part, which is good, right? Why do we need that vasodilation to occur there? What's going to happen if those vessels are larger? What's it going to permit? More volume to get there, which with that volume comes hemoglobin, comes the cells necessary for repair, correct? Comes fluid, plasma. All of that is a good thing because it's going to help already start protecting and healing this injured area. So that is going to be red. How's it going to feel to touch that redness? And it's because those vessels are at the surface and they're dilated, correct? All right, now there's going to be some serous fluid. What's the purpose of the serous fluid? Protection, right. It's going to protect the injured tissue, correct? Let's say a few days from now we see purulent drainage. What was the consequence that created that purulent drainage? What's the process called? Pac-Man. Y'all way too young for Pac-Man. I didn't like Pac-Man. Just want to tell you, I'm not one of those people. Phagocytosis, good job. Phagocytosis. So it's the end product, the waste product of our healthy cells destroying the bad cells. And this is the waste product. All of these things were normal and necessary, and in a healthy individual will take place that keeps him from getting what? Really sick. Keeps that pathogen from going any further. All of these localized effects are supposed to be there. The problem is, if we have people who are predisposed, who don't have a strong immune response, that localized response may not be enough to prevent the pathogen from going where? Through the bloodstream and begin to travel. Once a pathogen is in the bloodstream, where is it going to go? Wherever blood goes. So now this response that's ideally perfect in a localized setting is catastrophic systematically. Systemically is the correct word. You see where we're at right now? So we start thinking about, you remember I was telling you guys, I think on Module A, what sets you apart in your discipline as an RN from every other discipline is your ability to quickly and in moments strategize with your patient. What is your patient's highest priority? But you have to understand what they're at risk for. The only way you understand what they're at risk for is to have your education, knowledge, and training. Because if I can identify what my patient's at risk for, I can proactively implement measures to prevent bad outcomes, correct? Okay, but that takes me understanding who's at risk. Who's at risk for this? And remember, that infection can be anything. It can be a UTI, it can be pneumonia, it can be anything. But somehow a pathogen was able to successfully get through that bloodstream throughout the body. Now we have a problem on our hands, even if I were a young person, okay? So let's go through the steps, the processes here, and think about what's going on with my patient. So we have bacteremia. We'll have blood positive through blood cultures, bacteria rather. We had a primary infection that triggered that inflammatory response. And we're going to go through all these different steps. What is Sears criteria, et cetera, et cetera, et cetera. So some things you're going to have to commit to memory, like the normal potassium level, and this is one of those things. 3 T's and a W. You have to know these values. They have to be committed to you, like your social security number. Don't add any values, don't take away any values. Sears criteria are these 4 things. 3 T's and 1 W. So look at your temperature. If your patient meets 2 or more of these criteria, we have to put them on a sepsis pathway. So look at your temperature. You've got 2 variants here, a less than and a greater than. Your heart rate. Now, typically, the standard definition for tachycardia is what? Greater than? Right, but look what we have for a definition for tachycardia specific to Sears criteria. Greater than? Okay. We have a respiratory rate, tachypnea. That's classic with our standard definition. And then we have white cells, a greater than or a less than value. Janaea, was it you or Chloe yesterday that had a patient with a count of 3.5? It was you. Okay, so you see where we're at here? Remember I was telling you I was concerned about septic shock for this patient because this is what we're talking about. All right, so if your patient has met 2 or more of these values, we're going to put them on a sepsis pathway because what we're concerned about is, has a pathogen successfully invaded the bloodstream and we're starting to see that systemic inflammatory response. Now, will I sit back as a nurse and say, that's a chronic COPD patient. They always breathe greater than 20, you know, and they're always tachycardic because a lot of the meds they're on. And so I'm not going to put them on a pathway. Is that safe or unsafe? It's very unsafe. You've just tried to diagnose, number 1, just beyond your scope of practice. By the way, does the Board of Nursing let you practice beyond your scope of practice? The answer is absolutely not. The Board of Nursing is one of those entities you want to be on their approved provider list, but you don't want their attention. You got me? It would be unsafe for me to assume that this is what's causing that. No harm is going to come to my patient by me putting them on the pathway and saying, hey, we need to rule this out. But I can cause the patient's death by failure to do so. Because timing is everything right now. We have got to get on board and get ahead of this pathogen as fast as we can. Okay, so you're going to commit this to absolute memory, like a normal lab value, like your social security number. Because again, if you don't know what the normal criteria are, there's no way you're going to be able to build on that or act on that. And this goes back to my little soapbox thing about people who take vital signs. You are responsible for the values that are being obtained, regardless who got them. So you know what? You might want to make sure they're accurate. I would. Okay? I'm going to make sure that the values that people are obtaining on my patients are valid. What kind of temp do you think we need to use here? Is this an axillary temp?
No.
No. This should be a core temp at minimum. Okay? And if you don't have the route access necessary to do a core, oral would be my minimum safe standard here. All right, so now some of these slides I'm going to go click, 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 because they're just reminders for you. We have endogenous within, we have exogenous without sources of pathogens. Okay, we know that. Which are of the 2 are easier for us to control, the endogenous or the exogenous sources? That's right. We can control the outside of the patient. We can't control what's going on inside their body or what predisposing risk factors they came to us with. But I can control what I've done for my patient. I can control what I'm bringing to the patient as far as my care, my pathogens I'm bringing. Okay? That's between those 2, you know which one you have power over. Again, we've got the very young and the very old. Y'all, I hate saying that because over 65 is not old. It's not. But you've got those 2 spectrums. And again, we know why. The young have an immature system, hasn't been exposed to a lot. And our geriatric patients are like, I hope to be soon retired. Okay? So we've got these 2 spectrums. All right? And with that adds inherent risks. Okay? Then we have people who are getting what kind of medications would predispose my patient to successful pathogen invasion? Immunosuppressive therapies such as chemo. What else? Corticosteroids. Because what do steroids do? They tell the inflammatory response to chill out, don't they? Okay? Which in later phases is great, but in early phases could have prevented this. So if I've got a system that was already dampened by steroid therapy, this patient's gonna be more susceptible to successful invasion, okay? What about the more lines and tubes? Don't we poke holes in places that never had a hole before? They all kind of holes, don't they? We put something in every orifice we can find. Does it matter my technique and the methodology I use to do those things? It does. Again, I'm going to tell you once again, you check yourself. If you know you're doing something you wouldn't do on somebody you love, you don't need to be doing it. Bottom line, okay? And I'm not going to lie to you and tell you everybody's just all wonderful and nice to you. They're not. They're not. But you are ethically and morally bound to provide that care for them, okay? So we're going to do things right. We're going to protect our patient. We're not going to expose them to additional issues, all right? So you got a little list of different things. Why would what is it about this that predisposes my patient to pathogen invasion? Multiple portals of entry. Y'all remember that from fundamentals? Portals of entry, procedures. So all these different things predispose my patient to risks. What about malnutrition? How does that play a role?
Not able to fight off.
That's exactly right.
If you hadn't had your Wheaties.
You don't have the energy for cellular repair. All right, again, moving right along. So what does it look like? Well, in the beginning, you're going to start seeing the evidence of the riverbank being widened in response to the systemic inflammatory response. So what value is going to go down when volume is proportionally reduced because the size of the space increased? Blood pressure. Isn't that the same mechanism of action of a vasodilator? Isn't it doing the same thing? It's causing this vasodilation. So we're going to start seeing some hypotension. And again, this is where mean arterial pressure is important. Because what did we identify in Module A as a necessary mean arterial pressure to sustain adequate organ perfusion? 65 and above. Good job, guys. So here we're going to start focusing on that mean arterial pressure. We're going to look at that. Here we have a narrowed pulse pressure. What did we say in Module A contributes to a narrow pulse pressure? A reduction of what? Stroke volume. I told you I wasn't going to lie. A reduction of stroke volume. What row, Roger? Now we start seeing elevated lactate levels. How does that happen? What's going on at the level of the organs that would cause us to have rising lactate levels? What do you think?
They're breaking down.
Say again?
They're
They're breaking down. This is true. Why? What's causing that? They're trying to work in an anaerobic environment. If we don't have adequate blood flow to an organ, thank goodness it doesn't clock out. It's like, okay, I'm going to continue to work for you just a little bit because I see this line of customers coming up. But I really want to clock out because you hadn't paid me. Okay? Thank goodness they continue to try to work for us, but unfortunately, as they continue to try to work in an anaerobic environment, why is it anaerobic? Because we have poor perfusion. Why do we have poor perfusion? Because we have systemic vasodilation. We have a river that has lost its forceful flow. Okay? The end product, the waste product, if you will, from that anaerobic metabolism is lactate. So we're going to start seeing rises in lactate level. When you get a lactate of 2 or greater, you start having some red flags. When you got a 4, you've got a septic patient. Okay? And then look at our renal function. We start to have evidence of renal dysfunction. Again, perfusion. And then hepatic dysfunction. Remember, in your liver is where your clotting organisms are. Look what's starting to happen to our clotting values and our platelets. Like, what's going on? Okay, well, that's a little complicated because there's another factor that goes along with that. All of these areas at the organ level where we're having this anaerobic metabolism occur, it will result in little injured areas. Again, if we have our lactate being produced, what does the body try to do when something's injured? It tries to help repair it. So here's where you're going to start seeing your fibrin being utilized. Fibrin's going to go to all these areas of endothelial damage. And what does that do to our other stores? It starts to deplete them. It's a very complex cascade. Doesn't that further impede organ perfusion, have all these little microclots everywhere? Okay, so you see how this is becoming a really nasty situation, where when it was localized was great. Oliguria, again, related to your kidney dysfunction now. And remember what I said, your brain is super sensitive to perfusion and oxygenation. Understand when you assess something, your orientation status assesses something completely different than your level of consciousness does. That's why it's alert and oriented. We're assessing two different parameters. So you're going to start seeing that level of consciousness decline. Your patient's going to become more what we call somnolent. Y'all remember that word?
Mm-hmm.
A little more drowsy, a little more difficult to awaken. Okay? Like, what's going on with that? Oxygenation can lead to confusion, altered states of mental status there, but can't we have a perfectly perfused brain but still be disoriented? Yeah, because there's other organic processes that can cause that. That's why they're separated into two different things that you're assessing, okay? So altered level of consciousness. We start having a patient that's becoming less and less responsive. What are we going to do? We're going to open up the dam and fill up the river. And y'all remember, this is your priority action, is to replace that volume. We didn't lose it per se, right? Even though there is some interstitial loss, because when Matthew injured his heel, would you not expect to see swelling occur very quickly? What caused the swelling, guys? Pathophysiologically, what causes the swelling? Okay, fluid is now able, through this inflammatory process, to enter spaces it couldn't enter before. We went from having a screen to a chicken wire. Molecules that were by nature and size not permitted prior to enter those spaces are now given cell wall permeability. In other words, changes, okay? So that's what constitutes the swelling. So systemically, we will have a degree of fluid that extravasates into the tissues now, which further compromises my perfusion, doesn't it? Okay? What we're going to try to do very aggressively is fill that space. We got to fill that space. Your ATI book, always bring this with me. Y'all, you are not helping yourself if you don't read this chapter in ATI. Okay, now it kind of puts all the different types of shock together. What does that say, chapter what?
37.
Chapter 37. You need to read it. And you're not helping yourself if you don't put all these different, because it's going to talk about a lot of different types of shock, but it kind of conceptualizes things for you. And it also stresses the importance of, if volume is what you don't have, volume is what you replace. I had a student a few semesters back, and these are the things that just haunt me. I'm like, oh, I wish you had not said that. She was an EMS person too, going through nursing school, but she said that she had a severe volume depleted patient who was also hemorrhaging, and they kept telling her when they were calling in, as she was treating the patient en route, to continue to replace volume, and she said, that just seems crazy to me. I put them on dopamine. I'm like, oh my God, why did you tell me that? I don't ever want to see you on my ambulance. Because it scares me that you have the audacity to think that you know more, when you clearly don't know what you don't know, or you wouldn't have told me that. Why would the dopamine not help a patient like that? There's nothing to increase. You've got vessels that don't have adequate volume. Now, what you going to do with them? You can only pinch them so much. Like, what's going to happen now? Nothing is the answer. And you've instead caused a lot of other consequences physiologically that can have a bad outcome for your patient. If volume is my problem, volume is my fix. Remember, I have a systemic pathogen right now. It is running around my body. The first and best and most effective thing I can do is fill the river. Okay? So what are your volume expanders? What are the fluids you would expect to find? LR and normal saline. Look at what our CVP has to be. What was a normal CVP in Module A? 2 to 6. Good job. Why do you think I need an 8 to 12 now? That's right, because we don't have normal vessels. We have larger ones. We need more to sustain that. So your CVP 8 to 12 is what we're striving for, okay? So these are some of the things we would do to measure to see if we've gotten adequate volume on board, okay? Would blood transfusion be the answer here? No, because we're not losing blood volume. We need fluid volume. If the patient doesn't respond to our fluid volume resuscitation, which is at 30 mils per kilogram, notice there's no time there. It's 30 mils per kilogram. You may have to free flow it. Get it in there, okay? Your provider may say, I want it over an hour. Most likely it will be a 30 mil per kilogram bolus. Get it in there. Let's get moving. If they don't, the vasopressor of choice is norepinephrine. That is your vasopressor of choice. You will see some providers use phenylephrine, neosynephrine, but it even if you do some extensive research on that, it's not indicated for the treatment of septic shock. It can be used in other types of shock, but septic shock responds best to norepinephrine. Okay? But that's after, so what are we doing here with norepinephrine? Okay, we've tried to fill volume in the riverbed, and now we're taking a backhoe and trying to close the bank back up, is what we're trying to do. Because our goal is to get perfusion to those vital organs. So Jay, what is your patient's extremities going to look like when we start that norepinephrine? You remember your patient?
Oh, the blue, yeah, the cool and blue.
Cool, mottled, grayish, blue, whatever, depending on your patient's complexion, you'll see a discoloration, and they're cool. Because that's what it's doing. It's pulling from the periphery, shunting to your core. Okay? All right. Priority, also, early on, get those blood cultures before you initiate an antibiotic. Why would I do blood cultures before I initiate an antibiotic?
So you know what you're treating.
That's right. Now, I'm an Army brat. My daddy flew Cobras. So I love the Army. I feel safe. I love growing up on military institutions. I love the sound of choppers and the tanks rolling by in the mornings and the soldiers, left, right, left. I mean, I grew up with that and I loved it. When you're dealing with, you send out your little scout helicopters, your OH helicopters to observe and find what's going on out there to communicate back to home base, what are we dealing with? I need an accurate picture, right? I don't need one little random militant group to go take out part of it and destroy my sample size that I really don't know what I'm dealing with, do I? When you start an antibiotic before you've obtained blood cultures, you're distorting the true picture. We've got to know who we're dealing with, what quantity are they, how virulent are they? You remember that term from fundamentals? In other words, how potent is this bad boy? How are we dealing with this, okay? So my antibiotics will follow after blood culture has been obtained. How do we obtain blood cultures? How many sites do we use? Two. Why do we use 2 sites?
So that she can compare it.
So that we know we have a legitimate outcome. When I do one sample, and maybe during my sampling I didn't exercise good caution, I didn't clean the skin well enough, and my sample comes back positive for staph, and I assume that, okay, well they've got staph. And it's erroneous because it was a sampling error. If I've got 2 samples and one sample comes back positive and the other one's negative, there's no way half the body's infected and half the body's not. So there was a sampling error. So we do 2, both should identify the exact same organism, and we had 2 different sites, okay? That's how we make sure that what we're looking at is true and accurate. Your method of obtaining blood cultures is really important, guys, that you use the proper technique, especially if you're drawing the blood cultures from a line. That you've swabbed your ports carefully, you've wasted your first draw, you've used your second draw, all these things, and you'll see that this semester through the intensive care, okay? Oxygenation is going to be imperative because your patient most likely is going to have intubated. Because this systemic response leads to poor perfusion to the lungs. We're going to see that same effect in the lungs that we saw in the tissues where fluid enters spaces it wasn't able to enter before, which is going to impede gas exchange, isn't it? And these patients become profoundly hypoxic and require intubation. Chloe, I think that was your patient we had on 95% FiO2, right? With the trach? No, not yours. Was it yours, Janaea? You remember what I'm talking about now? Okay. 95% FiO2. Can't go much higher than that. I mean, we run out of options. When you've got a septic patient like that, they become very hypoxic. Okay? So we've got fluid filling in the lungs, impedes gas exchange, and now we have a hypoxic patient. We're going to go ahead and start our VTE prophylaxis because we know people who are mechanically ventilated or people under any physiological stress are predisposed to increased hydrogen ion production, which will increase gastric ulcer development and then cause them to bleed. Okay, we can't have any of that going on. Glucose control, tight glucose control. What does your body do during physiological stress to your glucose levels? Does it increase it or decrease it? It increases it. Why? Because it's trying to meet an energy demand, right? I mean, I need my, I've never drank, I'd be scared to drink Red Bull. I don't know how to respond.
It's fine.
But it's like your Red Bull, is what?
It's fine.
You sure?
Sure.
I drink wimpy coffee. I do.
You just gotta do it.
Yeah, just need a little bit. I'll drink the whole can.
I'd be scared.
Don't do it, don't.
See, I'm not gonna do it. I'm not gonna do it. I'll just do it. But it's Red Bull for your body, okay? It's like, listen, we need some energy. I need some sources here. I gotta work. But we found that patients have much poorer outcomes when we don't maintain tight glucose control. So we're gonna be really stringent with this. We may even put them on an insulin drip if necessary. But we're gonna keep those blood glucose levels below 180. And I did not say diabetic. This is anybody, okay? Tight glucose control. So we're gonna be really busy with this patient. Let's just read that, that's interesting, moving on. Let's talk about the phases of shock. So we started with what? We started with a pathogen somewhere. It was in the lungs, it was in the bladder, it was from a central line that was inserted and then not cleaned using sterile technique, whatever, okay? A pathogen was successful at entering the bloodstream because of all the different factors we identified earlier. The patient became bacteremic. They started exhibiting Sears criteria. We put them on a sepsis pathway. Oops, indeed, they are septic. We have pathogens identified in the bloodstream. Now we start seeing that severe sepsis. We start seeing that early hypotension, changes in LOC, lab values starting to change, all as a consequence of poor organ perfusion. And then we proceed into the stages of shock. Now, this stage of shock has different names. It might be called compensatory, hyperdynamic, warm, you name it, they all mean the same thing. This is the body's hoorah session. It's like, okay, I'm gonna fight one more time. I'm gonna try really, really hard to overcome this. And that's what you're seeing physiologically. So you're gonna see the patient will look warm to, like you look at me like, I bet when I touch them they're warm. They got that rosy, flushed appearance. And I touch them, indeed they are. Because what I'm having here is that massive catecholamine surge is making the heart contract much more forcefully right now. So it's having a positive inotropic effect on the heart cardiac muscle. Those catecholamines are. It's like, muscle, you gotta do something because we got a problem, Houston. So through that catecholamine surge and that increased contractility, you're gonna see cardiac output either normalize or rise, and you're gonna see blood pressure either normalize or rise. Because it is compensatory. This is a phase that's like, I'm gonna try really, really hard to overcome this, and that's what's happening right now. However, behind the scenes, we're really not accomplishing a whole heck of a lot. Because if you look, your patient's LOC continues to decline. Renal function continues to decline. Hepatic function continues to decline. Glucose levels continue to rise. My gas exchange continues to become compromised. What is a hallmark of this phase of shock? It's that normal or increased cardiac output that is specific to this phase and no other. But when I look at all the other things that are going on with my patient, like, whoa, bounding pulse. Why? We have a reduction of SVR, okay, and concomitantly an increased cardiac output. Now, that reduction of SVR is not a good thing right now, folks, because we need the volume to be able to come back to this, to the core. If I have very little resistance systemically, what's gonna help shunt it back? Okay? So we see all these changes occurring with my patient. And while it may look like, oh, they look better, they're not. We understand this is a compensatory cycle, and the patient will not continue to go well. We still have all our compensatory mechanisms trying to work. We're increasing white blood cells so that we can try to continue to combat this pathogen. As the patient progresses, they go into what we call the late/cold/uncompensated/whatever you wanna call it. We're not doing good phase. Late phase, cold phase, uncompensated phase, hypodynamic phase, whatever, they all mean the same thing. We've progressed into a state of shock now where the body no longer is able to help itself. So we're not gonna see that cardiac output that's rising, it's gonna go down. We're gonna see pulses become thready and weak. My patient is at this point most likely not responsive anymore. I've lost urine output, I don't have any more. My clotting values continue to be skewed. My renal function continues to get higher. This dysfunction continues to show you on your higher and higher lab values. Your clotting factors are being depleted. Your patient's becoming really sick. They look bad at this phase. Like you can look across the unit and they're gray, dusky, or regardless of their complexion, you'll know. You're like, ooh, not a healthy color. They look this way. Okay, so this is our latter phase. What happens to your glucose? Remember, all of our compensation mechanisms are failing. What happens to my white count? All my compensatory mechanisms are failing now. So, what do we need to do? You guys, if you are running around with a nail in your tire, and every day you choose to go put more air in the tire as opposed to taking the nail out, are you ever going to get over having to put air in your tire?
No.
No. Medicine's going to be focusing on taking the nail out of the tire. Let's find the culprit. Who's doing this? And let's get rid of it. Who's the problem? And let's get rid of it. Because until we take the nail out of the tire, we cannot expect anything to ever get better. We're going to be continuing in this nasty little cycle. We've got to treat the cause. So medicine's primarily focused on who's done this? Who caused this situation? What are we going to be as nurses? We're going to be making sure that we're implementing orders in a timely fashion, and if we don't have them, we're going to be asking for them. Because I want you to look, again, I don't want you to memorize statistics, but I want you to think about this and take personal accountability. Every hour you delay getting your antibiotic on board, what is it doing to your patient's mortality rate?
Increase.
Every hour, 5%. If that's my Audrey or my Matthew, I'm not going to be happy with you. Right? If that's somebody you love, you're not going to be happy about that, are you? And you guys don't think in this day and age that people won't know these things. They can Google everything. And this is a true story. I saw it happen myself. Had a man come out, his son was very sick. He came out. He had Googled treatment of septic shock. And he knew that that provider said that I had ordered those antibiotics this morning. The provider told him that. So I've ordered the antibiotics. Here it is hours and hours later, and they had not initiated those antibiotic therapy. He was livid. Rightfully so. Did the nurse have anything to stand on? No. No. What was your excuse? You've got to get, so if you don't have an order for an antibiotic and the blood culture results are back, isn't it your responsibility to communicate that? And this is what they're going to do, guys. So blood cultures are drawn as soon as they're obtained while they're waiting on the results, because it's going to take a while. They're going to put them on a broad spectrum. Once they've identified who it really is, they'll implement a targeted measure towards that specific pathogen. But in the meantime, we've started coverage for the patient, okay? But every hour we delay getting that on board, we're increasing our patient's mortality rate. And that's not acceptable. Look what happens if you delay your fluid resuscitation. Mortality rate goes up to 7% every hour. And I want you to think about how fast an hour goes by. Flies by, doesn't it? It's like boom, gone. It's not always that it's intentional that nurses get behind. Sometimes they're just caught up in all this, what's going on, but you've got to be mindful of that. You have to, okay? And take responsibility of that. Now, nutrition, and remember, in your skills modules, you're going to have a lot of, as I just told you after the test, a lot of fundamental modules to do with those skills, because this is what it all looked at back here, is the basics. So what's the difference between enteral and parenteral? What does enteral mean? Sydney, what does enteral mean? Where am I going? If you can't answer, phone a friend. Very good. It's going, did y'all hear? She's soft-spoken, so sweet. It's going through the GI tract. If we're doing enteral feedings, they are going via the GI tract. Piers, what does parenteral mean?
Going through the vasculars.
Okay, so parenteral, we're in the IV. Enteral is going via the GI tract. Parenteral is going in the venous space. Which of those two do you think is best, and then why? Hollis, what do you think? Okay, before you answer that, I want you to think back to fundamentals. Feeding the GI tract promotes what? Motility. It maintains the structure and, most importantly, function. What's the function of the GI tract? To know when to absorb nutrients, when to utilize them, when to store them, right? Now, having said that, what regulates a parenteral? The pump. Now, you tell me which of those two is better for the human body. Enteral, without a doubt. There's one time, and one time only, you're going to use parenteral nutrition, and that's when we cannot safely go through the GI tract. A couple of my students I know have patients that had, Quan, I think you had a gentleman last week that had the bowel issue, do you remember that? And then one of my two ladies, didn't one of y'all have one yesterday? You did. We can't use the GI tract, it's not safe. There's either an obstruction, there's a mass, there's a huge wound there. It's not moving, it's not safe to go through the GI tract, and that is the only time we're going to give parenteral. Okay? Otherwise, we're going to use enteral nutrition. And remember, you guys, the stomach is like a Timex watch. It will take a lot of hurt. And there's this old saying, put your dog and your wife in the trunk and see who's happy to see you when you open it back up. You know, and your wife's like, you should have kept that shut. Because while I was in here, I was making a weapon. Your GI tract is very forgiving. Your stomach is very forgiving. It will do without perfusion for a while, and it'll resume function very readily, okay? And even in a situation where all of our organs are failing, your stomach tends to keep trying to work for you. It's like, thank you. Okay? The GI tract is always preferred over parenteral nutrition. The only time we use parenteral is when we cannot use the GI tract. And I'm spending time on this on purpose, you'll see. With that comes what are the risks associated with parenteral nutrition? What's one of the biggest risks associated with parenteral nutrition? Infection. Well, we don't need that now. Okay? Plus, a pump regulates how many amino acids are going to be delivered, how much glucose is going to be delivered, etc., etc., etc. Whereas the GI tract knows, hey, I don't need those amino acids right now. I'm going to store those a little while. Okay? And again, that's why the benefit. How early do we need to institute nutrition? Within the first day or two, minimum. Again, that's your responsibility. Have you investigated that? Have you looked at that and said, man, we haven't been feeding this patient. It's been day 2. We need to be doing something about this. Because without adequate nutrition, what is your cell function going to do? It's going to decline. It can't function. It's got to have energy to do its job. Okay? Nursing. Aseptic technique. You're going to be really diligent with this patient who's either at risk, or any patient, right? Am I not going to be careful with any patient that I'm not introducing pathogens? Frequent vital signs. Does anybody have to tell me how often you do them? What do you think would be your minimum vital sign assessment here, time frame?
15 minutes.
Could be, but every hour will be your minimum. If I've got a patient who's in dire straits, it might be every few minutes. Okay? But Q1 hour vital signs at bare minimum. Constant head to toes, making sure you're implementing your treatments right on time, and then monitoring all your lab values. And again, if you've got a PA catheter, this is an awesome thing, but we're not going to put one in unless they already had one. Why would we not put one in? Or increase infection risk, but Jay and Jessica, you guys got to see a flow track yesterday. Far less invasive device. It can be done through a probe or an A-line, and it gives me those values. I can still see my cardiac output, my cardiac index, my SVR, my stroke volume, my CVP, with this really cool device called a flow track. That's not near as invasive. Medications. Okay, so while we said that steroids can lead to this, remember that was because in the early phases we needed a healthy immune response. And not having something that would start a localized inflammatory response is a bad thing, because that will permit the pathogen to run rampant. But now that the pathogen is rampant, I need to slow that response down, don't I? Because systemically it's deadly, it's lethal. So steroids are not at all unusual. Narcan, I personally have not seen it used, but Narcan is theorized to reduce endorphin-mediated vasodilation. So let's just think about that for a minute. When I was younger, I ran. I ran until I was pregnant with my daughter about 5 months and broke my foot. You know, when you're pregnant, there's not a lot you can take for a broken foot, and it hurt like the dickens. And it kind of stopped my running days. I'd do the walking instead. But anyway, back to what I was saying. I never got that, what they call runner's high. I was like, I don't know what these people are talking about. And I've been running for years, and I've never got that, oh, I just want to keep going. I loved running because it was a de-stressor, but I can't say I ever felt that, euphoria, whatever. Somebody did, not me. But endorphins would have been what would have created that. Okay, well, with endorphin release, you have vasodilation. Well, when you're under severe physiological stress, we try to intrinsically kind of protect that brain, like, oh, you got a lot going on. Maybe you just kind of don't need the real big picture here. We're going to release some endorphins so you feel a little bit better. But when we do that, it drops blood pressure. So Narcan reverses this action. We know that under extreme physiological stress, notice I didn't say psychological, I said physiological, that there's going to be endorphin release, and we don't need that because it's going to further mediate vasodilation. So let's instead give them the Narcan, which will stop that. Again, I've personally not seen that implemented, but that's why it's theoretically good. Okay. We talked about our vasopressor already, norepinephrine. Vasopressin is another form of vasopressor. It's usually your second line. They can be up to 3 vasopressors at one time, folks. If I've got a patient that's not responding to one adequately and we're on a max dose, we need to add another, we might need to add a third. So your vasopressors, famotidine and your pantoprazole, we've got PPI, H2 blockers, etc. Because we talked about that physiological and stress-induced hydrogen ion production. We want to prevent stress-induced ulcers. And then Lovenox. Okay, this gets tricky-ricky. And I'm going to build on it when we get to DIC. But I want to refresh your memory on something that's happening right now. We talked about cellular destruction at the endothelial level. Remember? Right? And which increases lactate levels because of the poor perfusion to the organs. Well, all those little microclots that develop there with fibrin, because there's areas of injury now, and the body thinks, well, I guess I need to go fix this too. We got fibrin aggregating. What does aggregate mean? Come together. We got fibrin aggregating at the endothelial level, which is depleting my fibrin stores and further compromising organ perfusion. When we do the VTE prophylaxis, which we would do anyway because our patient's definitely not out walking around right now, it also, this low molecular weight heparin, or heparin itself, also helps slow down that fibrin aggregation, which kind of, in essence, in a layman's terms way, saying this, helps maintain your stores where you need them, like around your IV site. around your intertracheal tube cuff, your Foley catheter, etc. Okay? So, what are some complications? Your patient is going to develop adult respiratory distress syndrome. This is because of fluid entering spaces it couldn't enter before. We have profound compromised gas exchange. We're going to go into greater detail on ARDS on Module B. DIC, which I'm going to revisit again in a minute, disseminated intravascular coagulation, acute renal failure, GI bleed, heart failure. If your heart's not perfusing itself, it's not going to continue to be able to function adequately, which is why, again, why your cardiac output also drops. And then, therefore, it's going to lead to that dysfunction. Central nervous system dysfunction. We've got to have perfusion to the brain. The liver is eventually going to fail, and ultimately, as all of these organs are one by one clocking out, your patient's not going to survive. It's a grim outlook once we get to that later phase of shock. Their prognosis becomes very poor. So DIC, disseminated intravascular coagulation. There's something up here in big green and then up there in bold letters. A patient is not going to come in with a diagnosis of DIC and nothing else. DIC is always in a response to something else. It's never primary, it's always secondary. So if something's secondary, what do you need to treat, the secondary or the primary? That's right, you got to get the nail out of the tire. You're not going to be able to fix this problem. You're not, in other words, you can't fix DIC until you fix what caused DIC. So treatments are going to be primarily aimed at eliminating the cause. What we do for the DIC is not really treating the DIC, it's buying us some time. This is so you can look through the cathode, move. What does a patient in DIC look like? Well, you're going to start seeing very large bruised areas that don't look, they're like, okay, that's not a normal bruise. That is full thickness. What's going on there? You're going to start bleeding from places you shouldn't see bleeding from, like around your IV sites. Your Foley catheter is going to have blood coming back in it. Your central line will have blood building up around it. The eyes, you're going to start seeing bleeding in places we shouldn't see bleeding before. What's happened? We've depleted our fibrin. It's all in these little endothelial areas. And we don't have any more stores. Remember all those bleeding times got skewed from the hepatic dysfunction and our values? So they can do these different things, but it's not going to cure anything except this. The only thing that's going to cure DIC is get rid of what's caused it. These things right here are just to try to buy some time sometimes, okay? And don't get confused about, okay, you're like, well, why does it say give them heparin, but here we're going to give them vitamin K? Remember, there's different mechanisms of clotting, aren't there? Is vitamin K going to help maintain a normal PTT? No, because there are different parts of the clotting cascade. The heparin is going to buy us some time by storing fibrin, not allowing it to be utilized so quickly. Whereas the vitamin K is going to stop that other factor part that goes along with that clotting part, that part of the clotting cascade. We may try replacing the patient's plasmapheresis, giving them platelets, cryoprecipitate, first frozen plasma, but none of that's going to cure the patient. None of that's going to cure that DIC. When you get DIC, folks, you're in a bad place with the patient. Their prognosis is incredibly poor at this point. Here's just some more pictures of what it looks like and the consequences of it, okay? See all this bleeding around the eye? I don't know, this drives me crazy. I say it every single time I teach this. They shouldn't put two different people's tootsies. Clearly they're going different. You should have a comparison here of the same person's tootsies. It would show you the differences, okay? Anyway, whatever. But you can see what it would not perfused, okay? Labs. The state board knows there's no way you can memorize every lab value in that book, which is why you have references. However, there are some labs that they expect you to have committed to memory, like your basic chem panel, glucose levels, basic bleeding times, like what is your normal INR, what is your normal PT, what is your normal PTT, and those I would know for this exam. What are those normal values? A D dimer that is elevated tells me what as a nurse? Go ahead, Josh, don't be shy. What is a D? Who said it here? Somebody just said it. They have a clot. We don't know where. It's not going to tell me where the clot is. But it's going to say, hey, there's a clot somewhere in that body. Maybe a PE, maybe a DVT, maybe multiple emboli. It's like, you got clot or clots somewhere. Kind of like a SED rate doesn't tell me where the inflammation is, but there's an inflammatory process going on somewhere. So D dimer's elevated. Remember, we talked about lactate levels already. It's not going to want you, expect you to know what an antithrombin 3 level is. I don't know what the normal is for that. I've been doing this 35 years. I'd have to look at a reference range, and the state board exam knows that too. That's one of those little random labs. You're like, huh? They know that, okay? They want you to know your basic values. Look at our fibrinogen, really depleted here. Remember we talked about fibrin as being utilized at that endothelial level, further compromising perfusion, and what do I have now? Depleted levels, and that's robbing it from the places I needed it to be, okay? So, look over your basic normal lab values that I've discussed. As this happens, again, all your organs are starting to shut down. We call that MODS, multi-organ dysfunction syndrome. And you know, this is so hard because what you're trying to do is help one thing, but if this one organ system can't sustain a body, it needs a collaborative effort from the other organs. And when they're all shutting down, it's a really dismal situation. Okay, all these organs are shutting down. Your lungs will be the first to show signs. Don't look at 7 to 10 days. I've seen people change overnight. Okay, that's just in the grand scheme of things. How can this take place? Okay, don't memorize those things. Your lungs are usually the first to show signs. You're going to start hearing crackles. You're like, what the heck's going on here? And you're going to start seeing a change in your saturation levels. Like, what's going on here? Why am I requiring more oxygen? What is your patient going to do when they start having a reduction of their oxygen saturation level? How do they start acting?
Agitated.
They're going to start acting like they're restless. Good word. Anxious, restless. When your brain detects some hypoxia setting in, you're starting. There's that sympathetic stimulation. Like, what? Wait a minute. We got to fight here because something's going on. Don't know what it is. Okay. So a little bit of restlessness, anxiety, and then everything starts to shut down one by one. TSS is in this module too because it is a form of septic shock. It's just a little different by nature because A, we know exactly what the pathogen is. B, we know who our patient population is very specifically. And C, we know what triggered it, what caused it. So it's a form of septic shock, but with some very specified criteria. Treatment of my patient is going to be the same, essentially the same. So you're a school nurse and you've got little girls. Remember, the higher the BMI of the child, the earlier they're going to start their cycle. Okay? So you can have a 10-year-old who's already started her menstrual cycle. That 10-year-old little girl has mama who's a crackhead and daddy who's missing. Who's teaching that 10-year-old little girl how to use her tampon? Who? Her little 11-year-old friend who's in the same situation. Now, your responsibilities as a school nurse are to make sure your children are educated. You're not giving them permission to wear a tampon. My mother had very strict religious beliefs. I was raised Roman Catholic. And as Mama said, nothing goes there but your husband, including a tampon when they first came out. Okay? That was just, she was like, oh no, oh no, oh no. We respect parents' values, but what do we tell them? We're not telling them it's okay to use that if their parents, if this is something that goes against their religious beliefs or their cultural beliefs, but we are going to educate them on what's proper as far as care and how to use it should they choose to. What do we need to teach those children? Yes, because when these first came out, we didn't have any data. We didn't know because they were new. They were awesome, and trust me, as soon as I moved out of my mom and dad's house, I bought them. Now I'm way past that age. Just one aisle of Walmart, I'm just like, see ya. But I was like, okay, whatever, mama. This is much more convenient. I'm on my feet for 12, 15 hours a day. I ain't got time to be studying all that stuff. But as data became available to us, what did we find out? That the longer they dwelled, staph is naturally present there, is it not? It's on your skin now, isn't it? Kind of gross. Don't look at it under a microscope. You'll be heebie-jeebied out. You're like, oh, I'm bad. I took a bath today. There's stuff there. Well, we found that the longer they dwelled in that warm, dark, moist environment, the pathogen flourished. And what was normal flora now became a primary pathogen. And our patients became very sick. So they present with flu-like symptoms. They did a lot of research, like what do they have in common? They're all menstrual age, they're all female, they all had tampons in during that time frame. Boom, we came up with a conclusion. Now, I think the boxes tell you, don't they, ladies? Okay, I don't know. I think the boxes
It comes in there, a little
insert.
packet insert
Yeah,
in
the little
every box
insert.
Oh, it does?
Nobody ever really reads. Yeah, the
that you
paper.
throw away immediately, but
But,
there's-
you know, at least
yeah.
it's there, right? Okay, good.
That's kind of like on the chemical, on preparation H, you know, how it has the thing on the box about don't ingest orally, blah, blah, blah.
I know, but you know, that's really sad. It's like the commercials say, don't take this if you're allergic to it.
Yeah.
I'm sorry, but that's a sad day when we have to tell people, if you're allergic to this, don't take this. Anyway, back to where we were. We came with a common denominator. So my job as a school nurse is not to infringe on the religious or cultural beliefs of anybody, but I do have an obligation per my licensure to educate. Not give consent, but to educate. I want to make sure my little girls are safe. So we're going to talk to them about how often to change it, give them, you know, tangible times. You know, every time you change your second class, it's time to go to the restroom and change your product, whatever, okay? So our patients presented with that ache. What is general malaise? What does that mean?
Fatigue.
That's the case of I don't feel good. You know what I'm saying? I got general malaise. If you want to impress people, I got general malaise. They'll be on Facebook. Oh my gosh, they got this terminal. You're like, ooh, all I said was I don't feel good. They don't feel good. They had a fever. They had a rash. Now that rash was a little more specific here, and that was related to that staph. Okay. Otherwise, same cascade. Hypotension, and away we go. Okay, and we have a septic patient. Okay. Well, what's that about that? We did it. So you're gonna go back and do what, guys? I think that was it. That's the last slide. Is there one more slide? Oh yeah, whatever. Okay, we're there. We're done. Okay, so you're gonna go back. Now guys, let me tell you something. I'm a firm believer in this too. You control your future. I told you guys, I'm the first member of my family to have a college education. My sister was the second. You control your own future. You take control of it and you seize it and you do something about it. So instead of licking wounds from today, if you did not achieve the score you needed, that's done. It's behind us. There's nothing we can fix about that now. All we can do is take control of what? That's right. Now and tomorrow. What am I going to do about it now? So you're going to go back and look at what do you need to refresh yourself on. What do I need to work on? You're going to go back to those hemodynamic values we discussed, especially which one? CVP, because we've talked about that already today. You're going to go back and review the inflammatory response so you truly understand what's happening. Again, if you don't know what happens under normal situations, you are never going to understand what you're seeing happening in your patient or how these treatments are going to change that. You've got a lot of HCI work. Seize it and get busy with it. Don't try to check boxes. Y'all know what I'm saying when I say check boxes? Just like, ooh, I'm done with that. That's right. You're just clicking and going. You're not helping yourself. I want to use Pierce as an example. I want to see evidence of how hard you've been working. Based on a question he presented the other day, it was obvious. No way could he have formulated those questions without having put forth a tremendous amount of work. He could not have even intelligently discussed that. Why was he able to do that? Because he has been preparing. And I'm not singling him out, and many of you guys are doing a great job in here. Okay? Many of you are, as evidenced by your grades today. But if you refuse to take ownership of your outcomes, it's gonna bite you, and you only, okay? So let's get busy, let's work really hard on it. Don't wait till the last minute. What happens at the last minute?
Panic.
ATI may go down, they may be updating their server, who knows? It's too late. Uh-huh.
What time does ATI open?
Today, when I get back to my office, I'm opening it up. Okay, if you don't see it by this afternoon, 3:30, shoot me an email.
You said you're gonna open the,
All the skills modules. Oh yeah, now that may not be, I'll try today, but if that probably, more likely Monday, okay? It just depends on how much I got to do when I get back to my office. I got a lot going on right now. Okay, but I'll open ATI first before I even eat my lunch, okay? All right, guys, any questions? Is it Thursday? Is that right? Today's Thursday? Okay, good. That means you got a weekend coming up, okay? Use your time wisely, pace yourself accordingly. What are you going to review before you come to Dr. Neal's class on Tuesday? Dr. Neal does F. Fluid and electrolytes. Get busy, okay? Go ahead and start reviewing her Parkland formula and rule of nines. Okay? Parkland formula, rule of nines. Go ahead and be reviewing that so when she talks about it for the first time, you're not sitting there thinking, what? Okay? All right, y'all. Have a good afternoon.